Everyone, I'm good medicine side. 58 years old Mr. X, who is doing own business, presented with the presenting complaints of inability to hold glasses using the right hand for 1 day, difficulty in holding pen and writing for 1 day, and difficulty in combing hair for 1 day. Of presenting illness, he noticed inability to hold the glass with the right hand after awakening from sleep, and also felt weakness of using right hand, which is incidence in onset, non-progressive, and not associated with any headache, blurring of vision, vomiting, abnormal tonic-clonic movements, bladder or bowel incontinence. That is a history of difficulty in combing hair, and then history of all the symptoms are related to the right upper limb. History of a difficulty in combing hair, history of bringing food to the mouth, history of difficulty in holding a glass, history of difficulty in mixing food, history of difficulty in writing, but no history of tightness or looseness of the limb. But no other limb involvement, no upper limb involvement, no both lower limb involvement. And no history of any sensory loss, and no history of any cranial nerves involvement. So past history, so he is a known case of chronic obstructive pulmonary disease for 1 year and not on regular inhalers, and he is recently diagnosed diabetes mellitus and hypertension, not on medication. And then personal history, he is a chronic smoker and he is a chronic alcoholic. On examinations, patient is conscious, oriented, and afebrile with a blood pressure of 100/60 millimeters of mercury and pulse rate of 86 per minute, which is regular, equally felt in all 4 limbs, and no pallor, no ictus, cyanosis, clubbing, pedal edema, and lymphadenopathy. CNS examinations, higher mental function examination show is conscious, oriented to time, place, and person. Remote, recent, and long-term memory was intact, and attention span also intact. And he is a right-handed person. And there is a finger agnosia, agraphia, acalculia, and dyslexia. Cranial nerve examination, all 12 cranial nerves were normal. And then right upper limb motor system examinations, which is right upper limb should normal tone, reflexes are 3+, and there is in proximal joints 4/5, and hand grip is moderate. But left upper limb and both lower limb examination was normal. And other system, the sensory system, spine, cranium, cerebellum examination was normal. No neck stiffness. What is your clinical diagnosis? Summary: 68 years old male with a known comorbidity of diabetes mellitus, presented with a difficulty in using the right upper limb, which is associated with the dyslexia, acalculia, dysgraphia, and finger agnosia. What is your clinical diagnosis here? Before coming to our diagnosis, we will see how to approach the cortical stroke syndromes. So, the brain is usually supplied by the cortex part of brain and with 3 cerebral arteries: anterior, middle, and posterior cerebral artery. So, the anterior cerebral artery, the most of the anterior and middle part of the medial aspect is supplied by the anterior cerebral artery. The lateral aspect of the most of the part supplied by the middle cerebral artery. The posterior aspect of both medial and lateral aspect supplied by the posterior cerebral artery. And there are 4 lobes: frontal lobe, and then parietal, temporal, and occipital lobe. Coming to frontal lobe, the function of frontal lobes are personality, helps in personality maintenance, emotional control, social behavior, contralateral motor control, and help in language and maturation. If there is a defect in frontal lobe, then there is a disinhibition, frontal release signs, and then antisocial behavior, contralateral hemiparesis, then excessive dysphasia, and then incontinence. If the parietal lobe, the dominant parietal lobe functions are help in language and calculations. If there is a damage to parietal dominant part of parietal lobe, there is a acalculia, apraxia, agnosia, agraphesthesia, and dyslexia. So acalculia is difficulty in calculation. Apraxia is difficulty with skilled movements when a person has the ability and desire to do them. And then agnosia is loss of ability to identify the object or people. And then dyslexia is difficulty in learning. So the most common syndrome, like these group of symptoms, they name under one syndrome called Gerstmann syndrome. And there is an involvement of parietal dominant. Then there is a involvement of following symptoms. This is dysgraphia, acalculia, finger agnosia, and right and left indiscrimination. Coming to parietal non-dominant, in parietal non-dominant lobe functions are spatial orientation and constructional skills. When there is a damage to parietal non-dominant lobe, there is a neglect of contralateral side, spatial disorientation, constructional apraxia, and dressing apraxia. Coming to function of dominant temporal lobe, it helps in auditory perception, language, verbal memory, smell, and balance. When there is a damage to dominant temporal lobe, there is a receptive aphasia, dyslexia, and impaired verbal memory. So if there is an internal carotid artery involvement, then there is a no chance of involving ophthalmic artery also, that causes amaurosis fugax. If there is a stem of MCA, middle cerebral artery involvement, that causes global aphasia and dense hemiplegia. If it is a M1 branch, if it is a M1 branch of the MCA territory involvement, then that results in global aphasia and internal capsule is bad. If there is an involvement of M2 branch of middle cerebral artery, that again M2 branch of middle cerebral artery again divided into superior division and inferior division. If there is a superior division involvement, there is a motor involvement of face and arm more than leg, and that face and arm. But there is no vision loss, and there is a Broca's aphasia and hemi neglect. If there is the inferior division involvement of M2 branch of middle cerebral artery, there is no motor involvement, there is no sensory involvement, there is only quadranopia, Wernicke's aphasia, and constructional apraxia. Coming to non-dominant temporal lobe, the functions are auditory perceptions, melody or pitch perceptor, and non-verbal memory, smell, and balance. The effects of damage to the non-dominant temporal lobe results in impaired non-verbal memory and impaired musical skills. That is the syndrome, Kluwer-Bucy syndrome, which is the involvement of both the temporal lobe disease, which results in apathy, placidity, and then increased sexual activity and shamrage. Coming to occipital lobe, helps in visual processing. If a damage to occipital lobe results in visual inattention, visual loss, and visual agnosia. There is symptoms related to occipital lobe, Anton syndrome and Balance syndrome. Anton syndrome is bilateral occipital cortex involvement due to bilateral PCA infarct. It results in anosognosia and confabulations. And Balance syndrome is due to the bilateral parieto-occipital lobe, which results in cymatognosia and oculomotor apraxia and optic ataxia. So, coming.
People should move on to more the learning points here. It's more like a class you're taking. So here's a diagnostic thing. You made a diagnosis. What is unique about this?
Sir, specific.
Basically, it's a syndromic thing that you're presenting. I think in clinical meeting, we should be, it's something that is a diagnostic challenge or a management challenge is what. This is more in the purview of a routine, an update on a subject. I think in the interest of time, we'll stop here. Any questions? Just one comment. Somebody mentioned 2 kids. Some examiners take offense to that. So please use the word children. That's one. And again, try and as a clinician, I think you have to keep your differentials broad and say, these are the points that fit into a particular diagnosis. These are the things that are unusual, like the Hansen's, you brought out that, these are typical features, these are atypical features. Or the Hirayama's disease, where you said, these are the possible differentials. Again, those list of differentials could have been a bit broader. Because here you're trying to get your colleagues to think through. When there is a complex problem, think through what are the possible differentials. And often in medicine, you'll find, at least here, people have been evaluated outside. And it's that extra bit, okay, this doesn't fit in, what could it be? And those are the cases that you should bring for discussion. So I think we'll wrap up. I'm supposed to announce which is the best presentation. I would probably go for the Rayama disease. Sorry, we exceeded the time a little bit. Well done. All the best.